Good evening, everyone, and welcome to the third of the CanSG webinars. My name is Louise Irvin, and I'm a GP and co-chair of CanSG. The first two webinars are on our website, which is can-sg.org, and this one will also be recorded and put on our website soon. The theme of tonight's webinar is Childhood Social Transition, Clinical, Educational and Safeguarding Perspectives. The context for this webinar is the recent guidance from the government to schools on social transition and the current public consultation on the matter. This consultation will run until the 12th of March. The link is in the chat. We hope that after listening to the webinar, people will feel inspired to contribute to the consultation, especially if you are a parent, teacher, or school governor. The background to this, and the reason we believe this has clinical dimensions, is the interim Cass review report, which talked about social transition as a clinical intervention, not a neutral act, and one that could have significant impact on a child or young person's well-being and development. Hilary Cass noted the lack of evidence for risks or benefits, and that more knowledge is needed. The current evidence base is very poor, but what evidence there is suggests that not only social transition does not improve children and young people's psychological well-being, but that it can interfere with the natural resolution of gender dysphoria that occurs in about 80 to 90% of young people who previously identified as transgender. The website for the Society for Evidence-Based Gender Medicine has scholarly articles on the evidence about social transition. We've put a link to that part of the SEGM website in the chat. There are also some excellent articles on social transition on the Transgender Trend website. And we know that an independent group of systematic review specialists at McMaster's University in Canada has done a systematic review of the evidence on social transition that is currently in peer review and will be published soon. So watch this space and we'll make sure to publicize the results of that. We're delighted to have three great speakers tonight. First is Stephanie Davies-Arai. Stephanie is the founder and director of Transgender Trend, which is a UK-based organisation calling for evidence-based treatment of children experiencing gender-related distress and for science-based teaching in schools. Stephanie will be talking about what social transition means, how it developed as an approach, the historical context, and the evidence we have comparing watchful waiting with gender affirmative approaches. It also happens to be Stephanie's birthday today, and we're very, very touched that she chose to spend her birthday doing this webinar for us. Thank you, Stephanie. Next, we have Dr. David Bell. David retired in 2021 after 25 years as a consultant psychiatrist at the Tavistock, where he led a unit for the treatment of complex and serious psychiatric disorders. In 2018, in his role as academic and clinical representative on the Trust's Council of Governors, he delivered a report on the Gender Identity Development Service, which was the Youth Gender Service, which brought to the attention of the Trust very serious concerns about the service. This report became public and was one of the factors leading to the NHS review of the GID service and eventually the decision to close the service. He's a psychoanalyst and a past president of the British Psychoanalytic Society. David will talk about social transition from a clinical perspective, with reference to the Cass interim review and proposed changes to children and young people's gender services. Finally, I'm sorry to have to tell you that our third speaker, Jane Martin, is unwell and not able to join us tonight. But I'm delighted to say that in her place, we have Peter Jenkins. Peter is a counsellor, supervisor, trainer and researcher. He's a member of the steering committee of Thoughtful Therapists. Peter will present aspects of the talk that Jane was going to give, covering three main issues. One, how might materials used in schools to promote gender identity ideology persuade children to accept and act upon their message? Two, what are some examples of materials used in schools to promote gender identity theory? And three, is social transition a child safeguarding issue? Peter won't be able to stay on for questions, but you can read Jane's original paper on our website if you want a more complete overview of social transition plus supporting references. We really want plenty of discussion, So if at any time you have a question, please post it in the Q&A box at the bottom of the screen. We'll take the questions after we've heard from all the speakers. When we read out your question, we won't mention your name to protect your anonymity. We will disable the chat during the talks so as not to distract, but we will post links to anything we think you may find useful, and we'll enable the chat during the Q&A session. Finally, I will mention a bit more about this at the end, but we're delighted to announce that CanSG is holding an in-person conference in London on the 23rd of March on the theme of First, Do No Harm. And as I said, I'll tell you all about that at the end of the webinar. So I'm really delighted now to welcome Stephanie Davies-Arai. Thank you, Stephanie.
Hi everyone, I'm going to do a very quick general overview to get us started so we understand the context and beginning with what social transition actually is. So it may involve a change in personal appearance to more closely resemble the opposite sex, changing your name to a name associated with the opposite sex or a gender neutral name, and asking people to refer to you by opposite sex pronouns. It may involve official name change by deed poll or on a child's passport. And I'm only going to be talking about children. Personal style or dress in itself is not social transition. The little boy who likes to have long hair and wear pink is a little boy expressing his personality. He is perfectly fine as he is. He's only socially transitioning if he thinks his clothes choices means he's a girl and all the adults around him agree with him and start calling him a girl. Social transition demands actions from other people. So in schools, it's teachers and other children who socially transition a child by referring to a girl as a boy, by using he, him pronouns about her. The child does not socially transition themselves. The rest of the school socially transitions the child. It's the act of gender affirmation, which means affirming a child's gender identity. And gender identity ideology is the belief that human beings are born with an inner sense of being male or female, which exists independent of their sex or socialization as a boy or a girl. And that this inner sense overrides biological sex as the definition of the words boy and girl. So the action of calling a boy a girl is essentially the expression of a belief rather than having anything to do with the child. And it's the same with pronouns. By using wrong sex pronouns, we're saying that pronouns refer to a person's subjective feeling or identity and not to biological reality. So this is a problem for those who do not subscribe to the belief in gender identity. And it's a problem for children who cannot distinguish between a fact and a belief when adults tell them things which the child assumes to be true. Gender affirmation and social transition of children is very, very new. It was almost unheard of a decade ago. But since around 2013 in the UK, we started to see news reports of very young children being socially transitioned in primary schools. Historically, the globally accepted approach towards these children was watchful waiting, and this was a developmentally informed approach that considered each child's age, background, environment, and family relationships, and supported the child and the family accordingly, sometimes with family therapy, etc. And it was understood that childhood cross-sex identity, or gender dysphoria, as it is clinically defined, rarely leads to adult transsexuality, and the far more likely outcome was homosexuality. It was also understood that there are many possible factors behind a cross-sex identity, from being a normal childhood phase through to being an indication of trauma or sexual abuse and everything in between. Whatever the cause, most children, around 85% from the 10 studies that we have, would desist in these feelings by the end of adolescence, and only a few would persist. And numbers were very small, the majority being boys. The latest study of boys in 2021, which is the largest sample to date, showed nearly 88% desisted, and about 64% grew up to be gay. But that will be the last study conducted under the watchful waiting approach. There's no evidence to show that this approach caused harm to children or carried any risks, but it's been replaced by the gender affirmative approach, which assumes a child is transgender and that the outcome will be a transgender adult. So gender affirmation and social transition is not a clinically developed approach, but rather a demand by activists, and it's based on an adult ideological agenda, which has been applied to children. We now have the first study on children who've been fully socially transitioned under the new gender affirmative model, and it was published in 2022. And in this study, only 3% desisted, compared with the 85% desistance rate under the watchful waiting approach. Activists will say that social transition is harmless because it's not a medical treatment, therefore it is completely reversible. Even the Tavistock disagreed with this, expressing concerns that it may, in their words, foreclose options, which I think is a polite way of saying that really a child can be so thoroughly brainwashed into believing anything by trusted adults that it would be impossible to then change. They become fixed, their identity becomes cemented. And that, I think, is what the evidence shows from that first study into socially transitioned children. All of these studies are of pre-pubertal children, and that's because until the last decade, there simply weren't teenagers developing gender dysphoria. This is a completely new phenomenon. We've not only seen this change in age, but a change in sex from pre-pubertal boys to majority adolescent girls. As Dr. Hilary Cass pointed out in her interim report of the review of the Tavistock, this is the group we know least about. In schools, safeguarding is going to be covered later, so I just want to make a few general points about schools and existing Department for Education guidance and the new draft guidance. Using a gender affirmative approach as policy in schools is essentially a social experiment on this generation of children, as there is no evidence yet to support its safety. The Department for Education in their new draft guidance, although advising against social transition generally, seems to think that there can be exceptions. But I think in this area, it really is all or nothing. For practical reasons, it would be unworkable in schools, but also because just one child in the school being referred to as the opposite sex does the job of destabilizing reality for all pupils. There is no evidence to show that it's a safe model, and the risks to the child are serious. The cementing of what would probably otherwise be a transient identity, adult encouragement of the child towards a lifetime as a medical patient. In terms of learning, for younger children, it interferes with an important developmental stage of understanding sex constancy and sex stability. This understanding develops normally between the ages of around 4 to 7 years old. And this is when children learn that putting a dress on a boy doesn't change the underlying reality. In other words, it doesn't change him into a girl, and that boy remains male for the rest of his life. The social transition of just one child teaches all children that the most fundamental reality of being a human is not true. And in terms of health and well-being, the Department for Education guidance on mental health and wellbeing, this is existing guidance, states school and college staff are not expected to and should not diagnose mental health conditions or perform mental health interventions. Teachers are not health professionals and are not qualified to socially transition a child. Keeping children safe in education, which is the safeguarding guidance from the Department for Education, provides this as one definition of emotional abuse. It may feature age or developmentally inappropriate expectations being imposed on children. These may include interactions that are beyond a child's developmental capability. Children also are not health professionals and are not developmentally equipped to socially transition a classmate. And schools must never expect children of any age to perform what Dr. Cass calls an active intervention that can have significant effects on the child or young person in terms of their psychological functioning. I would suggest that that psychological effect is also true for the children around that child, children who are being told that the boy in their class is a girl when they can see that he's a boy and are being told or pressured to join in the pretense. The children who will suffer the most anxiety, confusion, and psychological distress are the most vulnerable groups: autistic children, those with learning difficulties, or speech and language impairments. A school is embedding deception, lies, and secrecy, and we saw a case over the weekend about the impact on children of that in a primary school. It does not create an environment conducive to learning or the well-being of children. And schools have a responsibility for the safeguarding, education, and well-being of every child in the school, and no child should be exempt from normal standards in each of those areas.
Thank you very much, Stephanie. A very thoughtful and profound contribution. I just wanted to remind people that if you have any questions for any of our speakers, just put them in the Q&A box at the bottom of the screen. And now I'm delighted to welcome Dr. David Bell to make his contribution. Thank you. I think you're on mute, David. David, I think you're on mute.
Can I just ask if there's a way of stopping these icons coming up on the screen of hearts and thumbs? I know it's people mean well, but I find it a bit distracting.
Okay, nobody post any icons for David, okay? No matter how much you appreciate him.
Thanks very much. I'm a bit old-fashioned. Okay, well, I'm pleased to see such a good turnout for this meeting. Some of what I have to say crosses a little bit with what Stephanie has said, and that's inevitable between all of us, but we come at it in a slightly different way. But first of all, I'll start with a general housing statement, and that is that all psychiatric and psychological disorders, and I mean all, take place on the boundary between the inner. So I'm just going to bring my thing up on the screen so I can read it on screen. It's a bit easier. Just a sec. Okay, take place on the boundary between inner and outer. That is, various kinds of psychological disorder will express themselves in completely different ways depending on the cultural context. For example, in certain countries, anorexia was unknown, and then suddenly there was a huge escalation after there was 1 or 2 cases reported in the newspapers. So that's something that we always have to bear in mind. And of course, there's been a huge cultural transformation. The huge escalation in numbers from about 50 in 2011 to nearly 4,000 in 2022. That's of children and young people referred for the possibility of changing their gender to GIDS, which was the national service, and also the radical switchover from being a slight preponderance of males to being a huge preponderance of girls, 80% or more. Again, that can only be explained by socio-cultural factors. And of course, it's rather tragic that the Tavistock of all places is a place that knows that, but never seemed to think about what were the cultural influences that were bringing this about. Therefore, if that's true, that sociocultural factors are so important in the manifestations of all psychiatric and psychological disorders, if you have a huge escalation in the incidence of a disorder, then you need to think about how you're going to think about it. And also you need to recognize it's going to be social intervention. There is going to be the major kind of intervention. So that is, whatever we decide about the new services recommended by the Cass review, the only kind of intervention that's going to have any real effect is effect at a social level. And here schools are absolutely at the center of it. There's a long history of psychological epidemics of psychological disorders in schools. It goes right back to Freud's day. And it's always been the case that girls are particularly affected. And I don't think we have a good explanation for that. In Freud's day, there were outbreaks of hysteria in girls' schools. One child would have an hysterical fit, and then a lot more would have it. And he had both a cultural and psychological understanding of that, which I'll leave aside, just to make the point. So the recent intervention by government in terms of action in schools or stopping harmful action in schools is very welcome indeed. And that, as I understand it, it's had support also from the Labour Party as well. For some time now, schools have been taking advice, and my word advice here is in inverted commas, from highly politicized organizations who have no clinical knowledge or experience and yet feel positioned to recommend the right treatment for children. This has done very considerable damage to generations of children and parents and confused teachers. I've had a number of meetings with teachers from girls' schools that have been invited to speak. And what I discovered that many of them were often highly skeptical of what they've been, in inverted commas, taught, but felt they had no alternative to the highly politicized training they were provided. We need to understand that teachers come under considerable pressure and just don't know what to do. And when they're influenced by organizations who are not trainers, but trans lobbies, as I said, who have no knowledge, and who've been given this license to influence young people and their teachers, then they're thrown into a very toxic and difficult situation. But we need to recognize, first and foremost, teachers are not clinicians. They are not authorized to make clinical decisions of this type, especially not on the basis of one size fits all. Each child needs to be carefully clinically assessed by those who have the knowledge and experience to do this. Of course, when I say that, I'm aware that there are major resource implications. Just to flag it up, even before COVID, CAM service were on their knees. Children with depression could wait 1.5 years to be seen. So this huge escalation caused by this epidemic of gender distress has caused a major resource problem. But in order for any child to get treatment, there has to be a huge change in resources to child and adolescent mental health services. So the Cass review is the biggest review ever undertaken as regards trying to understand the nature of and the treatment of children and young people with gender distress. I prefer that to gender dysphoria. I think it's a better word, gender distress. The report makes it clear that affirmation is the wrong treatment. What this means is if a child or child and family say Jane is a boy and should be called John, it's the wrong treatment to agree and to affirm it. That is that these children need to be understood. Affirmation can mean accepting what someone thinks, but that's not what is meant by affirmation in this context. It means agreeing with them. That is that these children need to be understood in the terms of their history and personal narrative. We need to understand how they came to feel uncomfortable with their gender and gender/biological sex, and how they came to express these problems. The approach should always be neutral and explorative, not affirmative. That's the wrong stance for any clinician in any situation. If someone comes and says, I want to get divorced, we don't say, oh, good for you. That's good. We'll help you in that. We don't understand who this person is. We don't understand what divorce means to them. And we don't understand what it means at this stage in their life. And we don't understand why they're so certain about it. So we want to explore it. So if it's the wrong treatment in the clinic, which is now pretty established, how can it be the right treatment in the school? There seems to be a situation where the left hand doesn't know what the right hand is doing, or more properly, there's a profound disconnection in different aspects of child mental health, such as in the school and in the clinic. Social transition is affirmation. What has been lacking here is, as I say, joined up thinking with all the evidence that we have, and to use that to push aside the ideological-based misinformation and so-called guidelines that have been provided to schools. One of the things, as a general thing that's already been alluded to, is very important, and that is it's often thought that this is a progressive move in terms of understanding the spectrum of gender identity. It's not, it's a regressive move. Because we all, I say liberal thinkers, rather celebrate a spectrum of gender identity. But this is promoting a binary form of thinking, where if a girl isn't a girly girl, then maybe she's a boy. Schools have been lured into this binary position, and this acts profoundly against the interests of children being able to express their gender in non-stereotypic ways. Some children do not conform to stereotypic gender norms in terms of their play or preferences of dress and so on. In other words, they are gender non-conforming. This does not mean they were born in the wrong body, although their sex was somehow wrongly assigned at birth. But a young person who does not conform to gender stereotypes must not be told that their non-conformity means they're really not of their biological sex. Many of these gender non-conforming children will grow up to be gender non-conforming gay or lesbian adults. That's why the LGBT movement sees gender reassignment and early social transition as a form of conversion treatment for young kids who are confused about their sexual identity. When I did my investigation at the Tavistock, I discovered that the clinicians seem to have no interest in the sexual development of these children in terms of what kind of figure they were attracted to, only in their gender. Of course, these are completely intertwined. So as Cass, and we know that many children who are confused about their gender, their sexual orientation, may pick up either in themselves and their parents or the world around them a hatred of homosexuality. And therefore they become very disturbed about feeling themselves attracted, if they're a girl, to girls. And then may have the thought, well, maybe I'm a boy. And then that gets massively supported. So Cass is clear, it's been said that social transition is not a neutral act. It's a clinical decision. And it sets the child on a pathway that it becomes increasingly difficult to reverse. It's often said that these things are reversible, and maybe I'll say more about that in the discussion. But it's very difficult to reverse for these children, particularly if the schools are already involved. They come under pressure from their peers. But also, if they say they've made up their minds, it becomes a very shameful act to change their minds. But also, if they're on puberty blockers, the possibility of puberty, in other words, developing the sexual characteristics of their natal sex, becomes increasingly terrifying. Of course, it's also collusion with a delusion that you can change your biological sex. We shouldn't harm children by supporting delusional ideas. An important fact is what has been called diagnostic overshadowing. That's a term that Hilary Cass introduced. What she means is that referring to a child as transgender then becomes explain-all for everything and overshadows all the other, often very severe psychological problems that the child is suffering from, such as autism, over 35%, depression, long histories of psychiatric disorder. I've seen so many adults who had long histories of psychological disorder that were completely sort of blindsided once the decision was made that they were, so to speak, transgender. And of course, a lot of these children have suffered trauma, abuse, and some of them are just lost in the world. That is, this harmful treatment is an inverted commas pathway, provided until relatively recently, caused the child to suffer twice over. They get the wrong treatment, affirmation and social transition, and the other serious problems in themselves and often in the family too, are never addressed, as all is now perceived, or rather misperceived, through the prism of gender. Recent government advice stresses the importance of including parents, and we need to assume a position of compassion and respect for parents, not what became a kind of institutionalized suspicion. That is, the default position must be that they have the interests of the child as uppermost in their thinking. Parents will know the past history, for example, trauma, other psychiatric problems like anorexia, family crises such as bereavements, and so on. No clinician would diagnose or treat a child without full knowledge of the history and engagement with the family. The fact that this has been the practice, that is, without engaging with the family, is an example of a kind of exceptionalism that is applied to this group of children suffering from distress in relation to gender. That is, the ordinary canons of good clinical practice are set aside. I was going to say something more about homosexuality, but I won't, because often I think that's really been covered. And also we're going to cover safeguarding, I think, as well in what's to come, because that's also very central, that we have a responsibility towards safeguarding these children. But in the end, we have to realize the decisions about a child's mental health in this area is not a human rights decision. It's a clinical decision. Children are young, vulnerable, suggestible, and quite honestly, you don't need to be a great psychiatrist to know any of that. You just have to be an ordinary human being, particularly a parent. And they're not in a position to really understand the implications of the decisions they are making. Thank you.
Oh, thanks so much, David. Again, very thoughtful contribution, especially the emphasis on good clinical care and not doing harm. And the question you raised about if we're moving away from gender affirmative treatments in the clinic, as you say, why are they being promoted in schools? And isn't it time to stop that? So thank you for that. I'm now delighted to welcome Peter Jenkins of Thoughtful Therapists, who's going to talk. He's going to give Jane's talk, which she prepared earlier, but she couldn't do because she's been unwell. So thanks so much, Peter, for stepping in at the last moment. Thank you.
Okay, thanks very much, Louise. The paper is called "What is Social Transition and Why is it Important?" And I'm going to be looking at three key themes taken from Jane's paper. The first of these is looking at the role of social influence within schools and the related concept of suggestibility. Secondly, looking at teaching materials aimed at promoting social transition. And thirdly, looking at some of the parallels with previous experiences of social grooming and child abuse. Now, her paper is built around posing a series of questions, the first of which is, how might materials used in schools to promote gender identity ideology persuade children to accept and act upon their message? Social learning theory, developed by the psychologist Albert Bandura, proposes that humans learn by observing and imitating other people. When the teachers and peers are unanimous in promoting the notion that there is such an entity as gender identity, and that this is either independent of or more important than their sex, children will be motivated to pay attention, absorb, and retain this information. And due to their limited life experience, they are likely to believe it. The term source monitoring refers to the developmentally influenced capacity to distinguish between knowledge which is derived from a child's own experience versus information provided by an external source. The younger the child, the less personal experience he or she will have to draw upon with which to weigh up how to know whether something is true or whether it really happened. All parents will recognize this cognitive limitation of very young children in distinguishing between reality and fantasy, or having the capacity to fully understand metaphor. There is a significant body of research around children's suggestibility and relatively concrete thinking, their difficulties with source monitoring, and how far they can be influenced by constant repetition of certain messages. Much of this research has been undertaken in the context of seeking to improve outcomes in legal proceedings involving child witnesses, with particular relevance to cases of alleged child sexual abuse. Important questions arise concerning the ability of children to resist the suggestive messages repetitively delivered by ideologically driven teaching in schools, paired as they are with cute, glittery unicorns, pretty rainbows, and posters celebrating trans and non-binary gender identities, and reinforced by membership of special lunchtime clubs. The second question is, what are some examples of materials used in schools to promote gender identity theory? Well, there are many examples with rainbows and unicorns in abundance. An infographic known as the Gender Unicorn was conceived by the Trans Student Educational Resources Group in the USA and has been used in many UK schools to teach children the idea that there are 5 supposed dimensions of human gender and sexuality. The first of these is gender identity, which is depicted as a rainbow floating in a cloud of thought bubbles emanating from the unicorn's head. Now, it's challenging for any primary school child to appraise the information in a video which has been shown to children in some UK schools. This video is narrated by a 7-year-old in a dress whose parents, quote, "When they saw that that was truly who I was, they let me live as a girl," end of quote. Developmental limitations and the ability to source monitor can also be considered in relation to how children, like the one appearing in the video, arrive at the conclusion that they were always really a member of the other sex. When their adults have told them this on the basis of a preference for clothes and toys stereotypically associated with the other sex, a young child will have difficulty in distinguishing whether this was always their own belief or experience. The story about Thomas, the teddy bear, is delivered as part of the No Outsiders program, aimed at Key Stage 1, that is, children aged between 5 and 7 years. When presented with this story about a teddy bear who changes sex, primary school children of this age have only a limited frame of reference within which to be able to arrive at an informed opinion about the meaning of the content, because for them, it is entirely possible that people can change sex by putting on different clothes. It's similarly likely that children in Key Stage 2 will be confused by the metaphor intended by alienation. This is a storybook featuring alien babies who have found themselves originally on the wrong pastel-colored planet, but who become trans babies, crossing over bridges to a pink or blue planet or to a purple planet for non-binary alien babies. These messages are subliminal but effective, and they can act on children's brains to shape their thinking, attitudes, and behaviors in subtle but powerful ways. The third question is social transition a child's safeguarding issue? There is a prominent and growing body of opinion which sees social transition as part of a wider political movement which centers adult needs and wishes and has co-opted children as a necessary tool for the mainstreaming and survival of its aims. Aspects of social transition, such as breastfinding, have been conceptualized as a form of grooming or child exploitation linked with modern-day mainstreaming of pornography, which objectifies women and girls. Grooming is a term most associated with the exploitation of children by adults for their own sexual gratification. It's a form of child abuse, which has certain well-recognized elements, including befriending, giving favors, and, importantly, encouraging a child to keep secrets and isolating him or her from their parents. Groomers exert control by encouraging the child to see them as the child's true ally, while portraying their parents as being abusive. Many parents of trans-identified children have vividly described the ways in which they've been estranged from their children if they did not agree to affirm the new gender identity as a step along the pathway of social transition. They say that this has prevented them from being able to protect their children from the consequence of decisions which are being facilitated by other adults external to the family who've established influence over their children and alienated them from their parents. Now, during the child sexual exploitation scandals in Rochdale and elsewhere in the UK, there was, for many years, a widespread set of assumptions across professions, including social care, the police, and healthcare. Those professionals asserted that the child victims were making, quote, lifestyle choices. They were seen as mini adults, competent to make informed choices to comply with what some powerful adults were demanding of them. Their supposed decision-making was, however, based not on true autonomy, but upon a form of coercion, disguised as friendship, even love. This is now widely accepted so that the former presumptions are thoroughly discredited and the statutory agencies are judged to have catastrophically failed those children. Perhaps there are still lessons to be learned from those events and the assumptions that were made at that time, assumptions about children and the balance between their autonomy and their continuing need to be kept safe and well by responsible adults. Listening to the child can sometimes mean that we are hearing someone else's script and not necessarily the child's own words. In conclusion, teachers urgently need informed, evidence-based and detailed guidance, which should include attention to relevant clinical issues and which takes into account that social transition is not a neutral act and that it may have profound consequences for children. Thank you.
Thank you very much, Peter. Very worrying descriptions of what's actually happening in some of the schools, and it must be very, very hard for teachers. And I think we are moving towards better understanding. The very fact we can have this webinar, we can talk about these things, the fact that there's government guidance, you know, it's got weaknesses, it's got strengths, but at least it's there. And the fact that we're having a consultation, these are all positive developments, which I think can go towards helping us to ensure that we are really safeguarding children in this context. So thank you very much. Now, we've got loads of really interesting and really good questions. Last time, we kind of didn't manage to get all the questions. So what I'd like to ask is if people answer, just try to keep your answers as succinct as possible so we can get through the questions. I know that Peter, because you were really speaking on behalf of Jane, you're not too keen to be there to answer questions. But if you do feel like jumping in and saying, "Oh yeah, I want to answer that," then that's absolutely fine. Okay, so I'm kind of probably just going to go through them in order. Some of them are about questions to do with other things, which I'll just quickly answer myself, but mostly they won't be. They'll be for you. So the first question really is, social psychologists have much to say about and research about identity formation to do with race, nation or sex. How should one interpret their silence in what has at last become a debate. I mean, this is, I think, the question that why so many professionals who should know better, who should know about this, have actually stayed silent. And why is it up to groups like ours to try to get a debate going? And is it changing? I suppose that's the next I would add. What do you think, David or Stephanie?
Do you want to go on this one, David? I mean, just from my perspective, everybody has been silenced when the trans movement kicked off. It was notoriously #NoDebate, and it was framed as if you questioned anything that you were denying the existence of trans people, and if you questioned the medical and social transition of children, you are wanting to kill trans kids. I mean, awful stuff. So we've seen research suppressed and challenged. We've seen, well, obviously people are concerned about their jobs and livelihoods. So I think there are legitimate reasons for people not wanting or not feeling able to speak out. And I wouldn't judge any individual person for the decisions they make. But I think now the climate has changed so much that I think it's time for people who perhaps felt it was too much of a risk before to start being a bit braver. What do you think, David?
I'd like to ask a procedural question first. Are we going to allow people, I couldn't remember, to put up their hand and speak or not?
No, sorry,
And
David. The way we do it is just
that's fine.
I
And
can't
someone's
watch.
asking, because there are things in the Q&A and in the chat.
Yeah, so we're doing the Q&A, and we have actually asked people to put their questions in the Q&A. And
Okay, fine.
now, every so often I glance over at the chat because it's hard to look at both, and there might be something there I might address. But there's loads of questions in the Q&A, so it's easier for me. I can see them, and I can just go through them. So I'm going to go to the next one. It's addressed to Stephanie. Well, not necessarily just to Stephanie. Stephanie used the term brainwashing to refer to the adults around the children who socially transition and remain in that view. I wondered on what evidence she was basing that assumption of brainwashing by adults on, as opposed to the reaction of adults to children who are encouraged to wait and see and continue to interact socially in their birth gender identity. So it's a question really, why are you calling one approach a sign of brainwashing and another one is the wait and see is presumably not?
Okay, essentially it's because the first one is presenting the child with an idea or a belief as fact. So this is when adults are saying to a boy who believes himself to be a girl, yes, you are a girl, what pronouns do you want us to use? And then, asking the school to do the same thing. That's based on a belief. Whereas adults who say to the child, no, you're not a girl, you're perfectly fine as you are as a boy, are telling that child about reality. And it's the adult's responsibility to bring children back to reality when they're in the land of fantasy. And of course, we allow children to be in that fantasy land a lot, but also we know that there are certain things that children need to be corrected on. So that's the difference there. I think the parent who reassures the child that they're perfectly fine as they are, they can wear the clothes that they want, it doesn't mean that they have changed sex, are the ones who are guiding that child, because the child, it's stronger than suggestibility. Children's very understanding of reality is based on their interaction with the environment and what adults tell them. So essentially, I think I use the term brainwashing to show that the same message repeated again and again, yes, you are a girl, and is a form of filling that child's brain with information that is not correct, and that child will actually never grow up to be an adult of the opposite sex, so that it's taking over the child's brain and influencing the child in a direction that is not based on reality.
Thank you. That's a very good answer, I think, an interesting answer. There is another question here. Dr. Bell has said he prefers the term gender distress to gender dysphoria, but from memory, Cass says that some children, quote, thrive in a period of gender questioning. I wonder if using any of these terms that include gender is using the language of the captured. These children are actually just confused about their sex and the associated stereotypes. This is a question about language, which I do think is a very difficult one, because we do have to use language in a certain amount of shared language, and nearly everything you say, opens up all kinds of other questions, doesn't it? David, what do you think about why even using the word gender? Is it just adopting the language of the ideology?
I think that's an extremely good question. It's true that we have to use language, but I think this is a very important question, really, because I'll put my cards on the table now. I think it's always wrong to refer to a child as transgender, because, as someone else said, it forecloses things. Once you use that term, you've pigeonholed and you've functioned as if you know what's wrong with the child. But I'm concerned about the new gender hubs that are being created. I think Cass has done obviously a fantastic amount of work, but I do have a concern, and that is that once you call it a hub for gender dysphoria or children with gender problems, the moment the child is referred from the CAM service to the gender hub, they're transitioning in a sense, because they're now under the gender service. Now, I know Cass is hoping that once they get there, they can have their other problems attended to, and majority, of course, will not transition, and none of them will go on puberty blockers. But nevertheless, I think using that term, I think in an ideal world, all these children would be dealt with, and this supports what the person is saying, in an ordinary CAM service. The trouble is the CAM service don't have the resources. But so what happens in a CAM service is they're completely overwhelmed. Some clinicians just give up because they can't bear the idea that they can't see a child, for a number of sessions to help them, and they have to wait a year or two to see them. So if the child puts on their form, or the parents do, they have a gender issue, then they'll say, thank God, we can send them straight to the gender hub. And that's exactly what happened on GIDS. A lot of the children were referred to what was thought to be a national service for psychological treatment and assessment for children. So the clinicians would think, oh, well, we're sending them to the best service, but they weren't. They were sending them to the worst possible service because they were being harmed there. So I think it's a big problem. I do think probably, I think you have to keep always in mind, this is a child with problems and we don't know what it is. And they're presenting it as a gender problem, but I agree, even saying that one should have, a question mark around it, and one should never see it as primarily a gender problem. I just want to add one thing about scripting. That is that some of the clinicians who spoke to me on GIDS heard the children being scripted in the waiting room. If they ask you how long you've had this problem, say since you were 3.
Mm-hmm.
This is because some parents were completely on side for very complicated, often family reasons. Some of them, the mother had been sexually abused and couldn't bear the idea of her child becoming a girl. But the idea that a person can be scripted actually just throws a coach and horses through the idea that what a person said can ever be taken at face value. Every clinician knows that. It takes time to get through the script anyone brings to get underneath it. But they were just following the script. I'll shut up now. Thanks.
Thank you very much, David. Yes, because there's, as I said, loads of really good questions. So this is a question. Does the approach, quote, teachers are not clinicians, children need careful expert assessment, unquote, risk overcomplicating things for schools in relation to gender identity? These children's situations may be complex, but the solutions are surely quite straightforward. in relation to practical questions like toilets, changing rooms, or even pronouns. For example, nicknames and personal style are fine among friends, nothing to do with the school, which can then focus on whatever other problems the child has. So are we overcomplicating things with these children? What Stephanie, what do you think?
I think that's spot on. I think the issue for schools is actually really simple. In law, those children are under 18. They do not have a gender recognition certificate. A boy is both biologically and legally male, however he identifies, and same with the girl. It should be very, very simple for schools. And schools are based on clear rules that everybody understands. And the clear rules should be the approach in schools is based on sex, and any child that feels uncomfortable with that or wants to be treated in a different way to that, some accommodations can be made, but not many. And that should be the rules of the school. Now, that's really simple because that means that a school is operating as a school should. It's not giving special privileges or treating any one child differently to any other child. Every child is safeguarded to the same extent. Every child understands the rules. And you know what will happen now if schools revert to that is that there'll be a huge fuss kicked up by teenagers especially. They'll call their school transphobic. They'll, moan about it for about 2 weeks, and then they'll get used to it. And it's the same as, when we look back at school rules. So I hated wearing a skirt to school. I absolutely hated it, but I had to. And so that, when I look back now, at the time, I thought my teachers were mean. I thought the rules were unfair. I railed against them. Looking back now, I can see those rules held me safely and protected me, which you only understand that when you're older. But absolutely, yes, it should be very simple for schools.
Thank you. Thanks very much. Next question. Are there any research studies you're aware of that are looking at the psychological impact on the other children in a school where a classmate is being socially transitioned?
Not that I'm aware of, but there should be. We should not be looking, you see, schools should not be looking at one child. Now, Cass can do that in her interim report. Clinicians can do that. They have one child. A school has to look at the well-being and safeguarding of every single child in the school. And we've really neglected the side where, there are children who are siblings of the child who's transitioned. There are children in a school where a child has transitioned. What are the psychological impacts on that child? I think we won't find out for a long time, but I think those impacts have got to be there because you are taking the child, you're distancing the child from reality. And for good mental health, you need to have an acceptance and understanding of reality. And so we are bound to be causing damage. We just don't know what form it will take yet.
Thanks, Stephanie. I think this next question is one perhaps David might want to answer. If a child desists from transgender ideation, for example, if she's 13 when it starts, and then 15 when she desists, how likely will the desistance remain? Is identity stable by this point for an adolescent, or can vulnerabilities such as autism mean that they're still prone to pressure by peers to become trans again? So it's about the fluidity and the sense of sex and gender, isn't it? And the whole issue of actually detransition.
Yeah, I don't think there's an easy answer because particularly in any particular case, there's so many different factors. So just to give an example, a family child had been very disturbed since about 8 or 9. The family were beside themselves. The child then went online, was online all the time, but became attracted to transgender and announced that the problem was that she was trans. And the parents were terribly relieved. And one can understand that because any parent feels such guilt when they have a mentally disturbed child. It's terrible. So then they thought, oh, it's not us, it's not the family, It's not. It's this thing that they've got. The reason I give that kind of example is that they will be very resistant to an alternative. So if that child, for example, decided I'm not trans, and family dynamics may reinforce it again. So there's so many other issues going on in the child, in the school, in the immediate culture. However, all that being said, it is probably, I think one of the things that we have to think about is sexual identity. And children, more or less, by 16, 17, they know what their sexual identity is. They know if they're gay, for example, or lesbian. And that it's very important to disentangle these, because so many of these kids are really gender non-conforming gay and lesbian kids who have got various other psychological problems. So there's no real answer to it. It's reasonable to think that things will become stable the older that they get. That's a fairly obvious thing to say. But it's also reasonable to think that if there's a crisis and they go back online, they may decide, oh, I need to transition. And there are kids who have gone back and forth, transition, detransition. Even some, in inverted commas, clinicians have said, that's all right, you can have surgery and we can detransition you afterwards. We can make artificial breasts.
Yeah, which is another lie that some adults tell some young people, isn't it? You can just grow some new breasts. So there's two quite interesting questions. It's very frustrating because there's loads of interesting questions. This one is, I'm glad Peter brought up the relationship with the Rochdale and other towns' child sexual abuse scandals. I think this is key. The sexualization of children, especially girls, as girls are the vast majority of those with gender distress. The merging of boundaries between adults and children means that, just as you said, children are seen as mini adults with true autonomy and agency. We see this on social media, with adults presenting as children and children being prematurely sexualized. Why are those in charge of safeguarding so blind to these enormous cultural shifts and dominant messages? Stephanie, do you want to?
I wish I knew, because we all seem to have forgotten about safeguarding, and those who are in positions where their job is to safeguard children have, as Peter said, catastrophically failed. I'm so suspicious now of people who talk about children's autonomy and agency. We are, and another thing about gender affirmation in itself adultifies the child. It treats the child as a mini adult with the developmental capabilities of a child, but also the life stage. It's not just a developmental thing or a question of maturity. It's the life stage of a child. Children haven't developed the requisite cynicism, suspicion of people. That's why young people are so easy to exploit. So it doesn't matter how mature a 16-year-old is. They do not have they're not at the life stage where they can be making decisions that affect them for the rest of their lives. So we seem to have, and I think that this has happened quite gradually over the last couple of decades, given more and more rights to children and young people. And it's almost as if it's seen as cruel not to. And what we've forgotten is our role of adults and as adults, and the responsibility of adults to protect children and continue that protection into, the older teens and young adults. They're still young people. They're still starting out in life. Mm-hmm. And as older, cynical adults, it's our role to protect those young people.
Thanks very much. And that actually...
Can I say something there?
Yeah, of course.
Two things. One is, I think this is a very important, you see, because the thing, it manifests itself as being liberal and emancipatory, but it's actually tyrannical and oppressive. Because it's, when I went to a talk, conference given by detransitioners, the first one who spoke said, I speak for a generation of children who have had their capacity to have an imagination taken away from them. That was an amazing comment. So that is, the child's cry, maybe I'm a boy, maybe I'm a girl, maybe I do this, is taken away with this tyrannical movement, which manifests as if it's being liberal and emancipatory and makes people who are questioning it appear, transphobic or whatever. The other thing I wanted to mention, of course, was pornography in this relation, because I've talked to many young women who, pornography is so available to girls online, and it spreads out from boys see it too, and quite young kids think now this is what they're supposed to do. Some of us come from generations of feminists where women owned their body. In fact, in many ways, that has been very much infiltrated so that young girls feel called upon to do things or think they ought to do things that they don't want to do. And that can lead them to feeling frightened and hateful towards their sexual body. As one young woman put it to me, when the doctor told me that I was right, that I was in the wrong body, I thought he was agreeing with me that my body was ugly because it was female. So, but pornography has a huge effect. I also wanted to acknowledge that I just noticed in the chat, and I think it's important, someone's corrected me and said, be careful in saying that what we call choice of sexual object is relatively fixed. That's quite right to correct me. Increasingly, we're seeing, particularly women, it's not so common in men, particularly women who have been heterosexual, switching to being either bisexual or lesbian. And that's an interesting, again, it's an interesting social cultural phenomenon, how that happens. And I think I'm right to be corrected on that. So thank you.
Thank you. Thanks, David. And the next question, actually, it leads on to something Stephanie was talking about, the older, well, the young adults, over 18. So the question is, for those of who had a kid embark on this path over 18, I keep seeing people say over 18 should be allowed to do what they want. Yet the criminal justice system recognizes brain maturation takes till 25. Are the panel also keen to protect our young adults? And I know that we are concerned about that in CanSG. This is the next thing that we want to really look closely at. But yeah, what do people think? What does David and then?
Well, I've been quite involved in that. First of all, one of our members in CanSG is a neuropsychologist, and there's a lot of evidence from neurophysiology that brain maturation doesn't really end until 25. And within the health service, it's been a kind of acknowledgement that kids between 17 or 18 and 25 are a special group, and we provide special services for them because they're not yet adults. The only service where that doesn't take place is, guess where? In gender. Kids of 17, we have the huge waiting list at the Tavistock. So immediately the children are 17, they're sent to the adult service. The adult service, they're treated as adults, and the adult service is completely captured ideologically. So there's no real assessment at all. And I've tried to raise this with the Tavistock, and but the thing is, it's the adult gender services are run by a specialty board. There's about 6 or 7, maybe 8 adult services around the country, and they're all taking kids of 17. In fact, children of 17 in some services, say 17, 18, are 50% of the referrals.
Yep.
So there's a big job to be done. And Hilary Cass recognizes that, but, in a certain sense, her hands are tied because, what her work was aimed to do. But it's certainly true that we need to be doing things to protect the 17 to 25-year-old age group.
Thank you. And Stephanie, what do you think?
Just so I'd agree with everything David said, and it's something we've been highlighting for years, the adult clinics, and that, this sort of 17 to 25-year-old age group in other areas is distinct, but not here. I'd like to add to that I think it's a particularly vulnerable stage of life because often these children are leaving home for the first time, they're starting jobs, or they're at uni, and they might be alone away from their families for the first time, and so they're uniquely vulnerable for that kind of peer pressure in those groups, and they're also outside any sort of control by their parents or advice or help or support from their parents. Parents feel really helpless with the sort of 18-year-olds onwards, because really they have no say anymore. It's all and so parents wringing their hands, knowing how vulnerable their child is, and and yet they're not, you know, it's totally inappropriate to treat these 17-year-olds, 17 to 25-year-olds in the same way as adults, although I would add that those adult clinics are totally inappropriate treatment for anybody, but particularly that age group.
Thank you. And I think we will probably have a webinar at some point, a CanSG webinar on this very question. And some of the questions that have come in are on issues to do with conversion therapy and other issues. I will just say that we've got a lot of material about conversion therapy on our website, and we did a webinar about that a couple of months ago. So please do look at that, because that's not really the topic for today, except when David said that transitioning children could be seen as a form of certainly gay conversion therapy, or not therapy, but practice. Just one question. I think maybe trying to look at something positive. Oh, I saw it and now it's disappeared. It was about, I wish I could find it now, because now it was about what do we do about this, and it was about the question was something about creating multidisciplinary hubs around the schools and encouraging children. Yeah, I believe that the disconnect between agencies mentioned by Dr. Bell is critical. What do the panelists think about the idea of developing a well-defined multi-agency mental health approach, a part of which is firmly located in schools, aimed at the development of critical thinking, building emotional resilience, and positive mental health management? So,
yeah, I'm really concerned at the moment about the mental health stuff that's going on in schools and the mental health organisations that have sprung up off the back of COVID. It's the latest way for gender ideology to get to children. So I don't think, you know, again, teachers are not qualified in this area. Maybe there should be, you know, places where schools can link to, but I absolutely agree. This should fall under normal mental health services, and those services should be free of gender, and children's issues then can be looked at properly, everything that's going on in that child's life. Yeah.
thanks. And David, do you want to answer to that point as well?
I
question?
think the idea of having something by the schools within the schools is very important. I just add a sort of story that when I went to a girls' school, one of the teachers said, we set up, because we're very conscious of mental health in this school and very proud of it, we set up a special service for children who were mentally distressed to come and talk. And within about 2 months, so many children were mentally distressed and needed to come and talk. So it's very difficult to set up a service, because the service seems to then create the customers.
Mm-hmm.
And this is true in psychiatry in general, that we know if you create services, then it increases the incidence of the children, for example, who were presenting as anorexic. Once there were lots of gender service presenters with gender problems.
I suppose the question was actually saying it should be about not so much the teachers being mental health specialists or even bringing in mental health specialists, but actually encouraging things that build emotional resilience, positive mental health, well-being, critical thinking, etc. But I think we're going to have to end that here. I'm sorry, it's 14 minutes past, and we said we finish at 15:15. I'm going to look into keeping a record of the questions and seeing if there are any that we could actually answer on our website for people too, because it must be quite frustrating to put a question and see that it hasn't been addressed. So I think that's the next thing we're going to have to start thinking about doing with these webinars. So first of all, I just very much like to thank our speakers, to thank Stephanie, David and Peter. It was fantastic. I was so grateful. I'd like to thank all the people who came to the webinar. Your thoughtfulness, your questions are fantastic. And many of you donated to the cost of running it. So we're really, really grateful for that.